Imagine, for just a moment, the highest stakes puzzle you can think of. You have this locked box, the human body, and somewhere deep inside, there's something that shouldn't be there.
A shadow, a mass, something you can just barely see on a scan.
And the clock is absolutely ticking. You have to know what it is. Is it benign? Is it something aggressive?
Exactly. You need its identity to save the person's life.
But, and here's the catch, you can't just, open the box. You can't perform major open surgery every single time.
Right. The cost of doing that is just too high. The trauma, the recovery, the risk. It's not feasible for a diagnosis. You need a shortcut.
A way to reach inside, grab a tiny piece of that mystery, and get back out without, well, breaking the whole thing open.
And that really is what brings us to today's deep dive.
We are exploring the incredible and surprisingly high-tech world of image-guided percutaneous core biopsy.
It is a mouthful, isn't it? But really, if you strip it all down, we're talking about this intersection of engineering, 3D navigation, and just high-stakes strategy.
And if you're listening and thinking, okay, so they poke it with a needle, how hard can that be? Well, prepare to have your mind changed.
Oh, definitely.
We're digging into this amazing presentation from the RSNA, that's the Radiological Society of North America, and their journal, Radiographics. It's by a team from the Mayo Clinic, Kenneth Zurcher, Mark Sugi, and their colleagues.
And what they lay out is that this is not just poking things. This is a full-on mission. You are navigating a needle through a living, breathing obstacle course.
Past beating hearts, lungs inflating and deflating.
Critical arteries, all to hit a target that might be the size of a grape.
It's like a microscopic Mission Impossible. So today, our mission is to unpack the complexity behind what seems like a simple biopsy. We'll get into navigation systems that work like augmented reality, needles with ballistic firing mechanisms.
And my favorite part, why sometimes hitting the bullseye is the absolute worst thing you can do.
Which is so counterintuitive, but why this really matters to you listening is that it's all about how medicine is evolving.
It is. It's becoming less invasive, way more accurate, and a lot more cost-effective. We're talking about turning a hospital stay of days into just a few hours.
So let's start with the hardware. I have to admit, before this, I just thought a biopsy needle was, a hollow tube.
A lot of people do. But it's more like a golf bag. You have different clubs for different shots. It is not one size fits all.
So the radiologist has to choose the right tool for the job.
Exactly. Is it soft tissue? Is it hiding behind bone? Is it dangerously close to a blood vessel? Each one needs a different approach, a different piece of hardware.
So one of the coolest things in the source was this coaxial system. It sounds like something for a stereo.
It does, right?
Yeah.
But think of it as building a temporary protected tunnel. If you need to take, say, 5 or 6 samples to be sure.
You don't want to be a pincushion.
Nobody wants that. It's painful. It causes trauma. So instead, you insert a larger introducer sheath. That's your tunnel that stays put.
Okay, I see.
Then you slide the actual cutting needle, the stylet, inside that sheath. You can go in and out, taking as many samples as you need, and the tunnel keeps the path clear and protects everything else.
That is so smart. It's like installing a service elevator.
Precisely. And it lets you do other things, too, like what they call track embolization. If there's some bleeding, you can inject clotting agents through the sheath on your way out. It's a built-in safety feature.
Okay, so let's get to the cutting part. The source mentions 2 main types, side notch and end cut.
Right, and they're 2 completely different engineering philosophies for how to grab tissue.
Let's start with the side notch. They mentioned the Bardman-Opti as an example.
Yeah, that's a classic.
Yeah.
So imagine a needle, but near the tip, there's this little recessed tray carved out of the side, a notch.
Like a little scoop.
Exactly. When you fire the device, and yes, they are spring-loaded, they literally fire with a loud click. The inner needle shoots forward, exposing that tray. Tissue falls in. And then a split second later, an outer cutting sheath snaps over it, slicing off the sample and trapping it.
It's like a tiny high-speed guillotine.
That's a vivid way to put it, yes. Now, the end cut device, like the biopins they mentioned, is different. It works more like a cookie cutter.
So it just punches forward and takes a core sample from the tip.
A full cylinder of tissue right from the front.
So my first thought is, why wouldn't you always want the cookie cutter? It sounds like you get a bigger, better sample.
And that is the million-dollar question. The answer comes down to geometry and safety. This is where specs like throw length become critical.
Throw length sounds like we're talking about a quarterback.
In a way we are. It's how far that needle is going to mechanically jump forward when you press the button. And once you click it, that's it. There's no stopping it.
You can't stop it halfway. Okay.
Now, imagine you have a tumor resting right on the aorta, the main artery from your heart.
Oh boy. I see where this is going.
You absolutely cannot afford to overshoot. If your throw length is 22 millimeters, but that artery is only 20 millimeters away,
You've just biopsied the aorta.
which is a life-threatening catastrophe.
Yeah.
So radiologists are constantly calculating that. The side notch lets you place the needle tip right next to the target. The end cut needs a clear runway in front of it to accommodate that forward plunge.
So the hardware choice is a risk calculation. It's physics.
Always. And the Mayo team really drives this home. Knowing the exact specs of your needle down to the millimeter is just non-negotiable.
This is a perfect lead-in to strategy, because the best hardware is useless if you can't reach the target.
Right. The body is a total obstacle course.
The source mentions some incredible approaches. Let's start with the transmediastinal approach.
The mediastinum is that central chest compartment. It is very crowded real estate. You've got the heart, the trachea, the great vessel.
All packed in there.
And navigating a needle through that to hit a tiny lymph node without hitting something critical,
Yeah.
it takes incredible skill.
But the one that honestly made me wince was the transosseous approach. That means through the moan, right?
It does. Sometimes a lesion is just hiding right behind a rib or the sternum. There's no safe way around it. The angles just don't work.
So, you go through it, you drill through the bone.
Essentially, yes. They mentioned a special tool, the Biopsy penetration set. You use a drill to create a channel through the bone's hard cortex.
A literal tunnel?
A tunnel. And then you pass the soft tissue biopsy needle through that channel to get the tumor on the other side.
That is just unbelievable dedication.
It turns an inaccessible lesion into an accessible one.
But then there are times you don't need to drill. You can just move the furniture around. Let's talk about hydrodissection.
Ah, yes. Moving the furniture is a perfect analogy.
It sounds like a superpower. How does it work?
It basically is. So let's say you have a tumor on the kidney, but the colon is lying right on top of it. You absolutely cannot stick a needle through the colon.
Because it's full of bacteria. You'd cause a massive infection.
Exactly. It's a total no-go zone. So the radiologist will guide a tiny needle into that little space between the two organs.
Okay.
And they inject a stream of fluid, usually saline.
Creating a water cushion.
Precisely. The pressure of the fluid physically pushes the colon away from the kidney. It creates this safe corridor of water that you can then pass your biopsy needle through.
You're temporarily remodeling the patient's anatomy to get the shot. That is brilliant.
And then the fluid just absorbs and everything goes back to normal. It's like temporary terraforming inside the body.
And sometimes it's even simpler. The source mentions just, well, patient positioning.
Gravity's a tool. Rolling a patient on their side, having them take a deep breath in and hold it. They can shift the liver just enough to reveal a target that was hiding under a rib.
Okay, so we've covered the hardware and the navigation, but this next part, for me, this was the real aha moment.
The donut theory.
Yes. The source says you can hit a tumor perfectly, dead center, bullseye, and still fail. How is that possible? You hit the target.
Because a tumor isn't a uniform block of plastic. It's a living, growing thing. And fast-growing tumors are like cities that expand too quickly.
The infrastructure can't keep up.
The blood supply, specifically. As a tumor gets bigger, the center gets farther and farther from the blood vessels. It gets starved of oxygen and nutrients. The center becomes necrotic. It's dead tissue.
So if you stick your needle in that dead center...
The lab just sees necrotic debris. They can't tell you what kind of cancer it is because all the cellular structures, the DNA, it's all broken down. You can't run tests on sludge.
So the valuable information is not in the bullseye. It's in the ring around it.
The hole in the donut is useless. You need the donut itself. The viable, living, dividing cells are all on the periphery, the outer rim.
The rookie aims for the middle, but the expert aims for the edge.
That's it, exactly. But here's the challenge. On a standard non-contrast CT or a grayscale ultrasound, the dead center and the living edge can look identical, just a gray blob.
So how do you find the life in the tumor?
This is where multimodality imaging comes in. You need tools that see biological activity, not just anatomy. Things like contrast-enhanced CT, which shows blood flow.
Or PET scans, right.
PET scans are the gold standard for this. They detect metabolic activity. Cancer cells are hungry, they gobble up glucose. So on a PET scan, the living parts of the tumor light up like a Christmas tree.
Which brings us to that first case study from the Mayo Clinic, this 76-year-old man with the liver mass.
This is such a textbook example. He had this large mass. A previous biopsy, likely aimed at the center, came back non-diagnostic.
The worst possible result. You go through the whole thing and still have no answers.
It's awful for the patient. So the Mayo team used multimodality fusion.
Fusion, it sounds so sci-fi.
It's basically augmented reality for doctors. They take a PTMR scan, which shows the hot, active parts of the tumor in bright colors,
Yeah.
and they digitally overlay it on the live ultrasound screen.
Wait, hang on. So the doctor's looking at the screen, seeing the live ultrasound of the liver, but superimposed on top is the color-coded PT data from a previous scan.
Yes. The system uses magnetic field trackers, so as the doctor moves the ultrasound probe, the PET map moves with it, perfectly aligned. You can see the hotspots glowing red and green right on the live image.
And in this case, the center of the mass was not glowing.
Exactly. The fusion image showed a metabolically active periphery, a glowing ring around a cold, dead, necrotic core, so the radiologist could steer the needle right into that glowing rim.
And the result was?
A successful diagnosis. Metastatic cholangiocarcinoma. Without that fusion map, they could have just kept hitting that dead center over and over.
That's just incredible. It's not about seeing the shape anymore. It's about seeing the biology, the behavior.
It is. Now, there's another case 2, that really highlights the hardware choice we were talking about earlier. A mass in the chest, the mediastinum.
Right next to the mediastinal vasculature.
The big vessels. The aorta, the vena cava, high-pressure plumbing. You nick one of those with a cutting needle and you have a massive hemorrhage in seconds.
So the margin for error is 0.
And this is where the choice between a side notch and an end-cut needle is everything. The authors explained they deliberately chose the side-cutting needle.
And why was that?
It's about the vector of the cut, the direction. They had to come in perpendicular to the blood vessel. So imagine the vessel is a wall and the tumor is right next to it. If you use an end cutter,
The cookie cutter.
right, you have to push it forward to cut. That forward motion is a direct path towards puncturing that vessel wall.
I see.
But with the side notch needle, you can lay the needle right alongside the vessel. The cutting action, that trap door, happens on the side. All the motion is parallel to the danger zone, not pointed at it.
Such a subtle detail, but it makes all the difference. You're cutting sideways instead of plunging forward.
That nuance is what defines an expert. It makes a potentially reckless procedure safe and controlled.
The source also mentions some other advanced imaging, like CEUS.
Yeah, contrast-enhanced ultrasound. So we think of contrast dye as a CT or MRI thing,
Yeah.
but you can use it with ultrasound too.
And what's it made of? Not iodine, I assume.
Microbubbles.
Microbubbles, seriously.
Seriously. Tiny gas-filled bubbles encased in a shell about the size of a red blood cell.
What do they do?
They reflect sound waves really well, so you inject them. And on the ultrasound screen, you can watch in real time as they rush into the tumor and light up the areas with good blood flow.
So you can find the living tissue that way, too.
And it's much safer for some patients. There's no radiation like a CT. And unlike CT dye, which can be tough on the kidneys, these microbubbles are just breathed out through the lungs.
Every single innovation is about seeing more clearly or acting more precisely. But the source brings it back to something practical. Cost.
It does. And it's a huge point. Despite all this high-tech gear, percutaneous needle biopsy is significantly cheaper than the alternative.
Which is open surgery.
Right. A surgical biopsy requires an operating room, general anesthesia, a hospital stay. The source points out that with a needle biopsy, there's reduced or no inpatient hospital time.
You go home the same day.
Exactly. You turn a week-long ordeal into an afternoon procedure. That's obviously good for the healthcare system, but think about the patient.
Sleeping in your own bed versus a hospital ward. It's no contest.
And getting back to your life, your family, your work, the quality of life difference is just massive.
So if we zoom out, what does all this really mean for medicine?
I think it's about the changing identity of the radiologist. For a long time, radiology was diagnostic. You took the picture, wrote the report, and sent it to the surgeon.
They were the photographer.
Exactly. But now, with these image-guided procedures, the radiologist is the interventionist. They're not just documenting the problem, they're actively using the images to get in there and solve it.
Moving from passive observation to active engagement.
With sub-millimeter precision. That really is the future.
It makes me wonder where this goes next, if we can see this much now.
That's the question, isn't it? As our imaging gets even more sensitive, we're finding tinier and tinier lesions. The hardware, the needles, they're going to have to keep up.
But is there a point where we don't need the needle at all?
That is the provocative thought to end on. Will we get to a point where the imaging is so good, so powerful at a molecular level that we can make a complete diagnosis from the scan itself?
A digital biopsy.
Potentially. Or maybe liquid biopsies, where we just take a blood sample and find the tumor's DNA floating in the bloodstream.
So the locked box stays locked, but we still find out exactly what's inside.
That is the ultimate goal. But for now, for solid tumors, this incredible fusion of engineering and imaging is the absolute best tool we have to solve that puzzle.
It really gives you a whole new respect for the phrase, "it's just a biopsy."
Absolutely. There is a world of strategy and augmented reality behind that one simple needle.
Well, that is all the time we have for this deep dive. A huge thank you to Kenneth Zurcher, Mark Sugi, and the entire team at the Mayo Clinic for this incredible look under the skin.
It was a pleasure to unpack.
And thank you for listening. Keep asking questions, and we will see you on the next deep dive.